So the prototype case I picked up, and that was due as our syllabus as well, Treponema pallidum. So it's like a spirochete. There are many other spirochete, but I think if you pick up syphilis, you pretty much will have a sense of what is going on in this particular bacteria. And again, as I said earlier, I borrowed it and copyrighted from CDC, where they have a standardized syphilis curriculum. I'm going to take you through that, and this is meant for all health professionals, including pharmacists. Again, there's a list of learning objectives, but I'll kind of trim it up for you, and I will take you through most important one. But as it says over here, I would definitely want you to know epidemiology of any particular STD, pathogenesis, clinical manifestation of a particular STD, in this case syphilis, and then again common methods, very common method in the diagnosis, and rest of it is for FYI, for your information, but at least you will go through that as a workshop to answer the questions as you did in gonorrhea group activity. So, as I said earlier, we will concentrate for epidemiology in USA because it's coming from CDC. Pathogenesis should be familiar to you. It's more of an immune response. Clinical manifestation, again, if you know pathogenesis, pretty much easy for you to guess what's going to be there. Diagnosis, very basic. Patient management, as I said earlier, for your information, and prevention, again, for your information, and especially if you're going to be there in this health-related field, it's always a good idea to know what's happening around you. So let's pick up epidemiology. And by definition, syphilis is a sexually acquired infection. And the causative agent, etiological agent, is Treponema pallidum. And the important thing for this disease is that it progresses in stages, and I want you to know what the stages are, and may become chronic without a treatment. So if you don't treat it, again, it will become a chronic, and as we already know, it's a part of STD, sexually transmitted diseases. And I told you the other day the difference between STD and STI, where you basically have a full-blown infection. Transmission basically is sexual and vertical. And what does vertical mean? Mother to the baby. So vertical transmission is mother to the baby. So that's another concern for those pregnant women. They want to give birth to a child, and they themselves have a STD. The other important thing is that I want you to know, especially if you are going to ask me what type of questions are going to come in the quiz, the most contagious to sex partner is during primary and secondary stages. So there are different stages of syphilis, but the transmission that happens between sexual partners happens during primary and secondary stages. And as for most of the STDs or most of the bacterial diseases, there always are history, but again, a little bit of historical perspective that it was very rampant, very rampant in 1940s. And once we had penicillin therapy introduced, and there were broad-based public health programs, is pretty much was taken care of. That's what we thought in 1940s. But also remember, things keep on changing. Sexually transmitted diseases are not only per se sexual, there's something to do with behavioral as well. So there's some tendency among people to go for that kind of promiscuity. And there are patterns that come and go. And you can see that we thought that we had a clue of it and we're going to manage it. But again, you have to argue is this the best management to let people do what they want to do and then give them penicillin? Again, you will agree or disagree with me, but the problem is that, again, it was kind of a license to kill or a ticket for whatever they want to do. So what happens in 1986 and 90, again, it comes back. 83% increase, which is enormous, in primary and secondary syphilis. And then again, good news comes back. In 1990s, there is a decline, and then all-time low in 2000. But again, don't get misled by this information, because they say that the incidence of STD in USA is like tip of iceberg. So you just see a small, tiny 1% of it, and it's more than what it is, because for obvious reason, people are not going to show up in STD clinics. So I'm going to give you some important concept-forming things that will give you an idea why do people do not show up in STD clinics, and what actually brings them to STD clinics, and what is your role and your responsibility. By all means, it remains a public health problem. And then again, MSM stands for men having sex with men. So that's another concept that came up, and CDC is aware of that. So these are the two terms that we normally use: WSW, women having sex with women, and men having sex with men. So these are basically our important risk populations that we have seen recently. Okay, so if you were to compare, let me grab my technology if I could. Right. There you go. So you can see from here, as I said, 1940s was a crazy time. 600 in thousands. 600 in thousands. I don't know what was happening though. I was born at that time. I'm not that old. 1940. But you can see early, latent, primary, and secondary. These are the phases. But it kind of deteriorated. There was a surge again in 91. But again, you will see that if you look at the pattern, it's always there. So this has never gone away. It's not like an infectious disease. You took care of polio, you took care of blah, blah, blah. But it's been there because this is a societal problem. And I just want to have I'm just going to stop. Can you call? Lisa, you want to come down for a second? Yeah, yeah. Just want to talk to you for a quick second. Yeah, I'm sorry. Okay, so most of the time we study this as an STDs because this is important. And then again, as I said, the ratios are different, especially for primary and secondary. And you can see 2011 areas, I wouldn't kind of discuss much, but it's present everywhere. Some of the states where you think it's not present because they're not been reported. I would kind of have that guess, because no moment, bad example, the moment you enter from one state to another state, you start showing up this trucker's place and all those things that maybe they are inviting your trucker, especially on a long haul drive, to go and help themselves and get serviced. Anyway. Primary and secondary is there. Again, you can see over here rate by sex, male to female rate. And you can see male, of course, have a higher rate because they're bold and more promiscuous as compared to the female rate. But apart from 1990s, there was a very surge. Pretty much you will see that for all practical reasons, male have a higher incidence than females. If you look at ethnicity, by all standards, it always remained above very high percentage with no comparison with any other ethnic group as to what's happening in black population versus Hispanics, American Indians, and whites pretty much static, and Asian and Pacific Islanders all the time low. So that's pretty much a standard pattern for, I would argue, for most of the STDs. and especially for syphilis. And this is a study done for the last 10 years. And then keep in mind, I'm talking about the primary and secondary syphilis. I'm not talking about the tertiary. Now, as I said, vertical transmission, very important, because you want to know that you're not giving it to your baby. And you can see from here, CS stands for congenital syphilis, PNS for primary and secondary syphilis. So this pretty much they're static. And then again, you do see quite a few cases over here. And this good thing is that many times if women themselves don't want to go and seek help for their STD, once they get pregnant, and if they're going to go for help for their pregnancy, they will screen them for STDs, and because they were more concerned about the baby being born. And I'm going to explain that to you, why is it so. As far as pathogenesis is concerned, again, how pathogenesis is a process, we want to learn how does one particular bacteria cause disease. That's what the pathogenesis means. And again, Treponema pallidum, very special thing for this particular bacteria is a corkscrew shape. So corkscrew shape is a typical, and is weird kind of bacteria. You would never see any bacteria like that. I used to wonder if it's really a bacteria or an artifact or a snake or whatever. But you can see a typical motile microaerophilic. It cannot be cultured in vitro. It cannot be viewed by normal light microscopy. So we have to have something we call dark field microscopy. And you can see from here, I mean, very weird pattern is an electron micrograph. And this is from CDC, Treponema pallidum. And it looks like a snake, a serpent. But the fact is, it is considered as a bacteria. So you cannot culture it, you cannot see it. So you have to have special techniques for dark field. And you can see a typical corkscrew pattern. That's what it is, corkscrew pattern over here. Especially if you were to see in human secretions. How does it penetrate the body? Again, it's a sexually transmissible diseases. And then again, the recipients will pick up from the sexual contact, that's skin and mucous membrane. And then again, for vertical transmission, is going to go transplacentally from mother to the fetus. And then when it goes into the lymphatic system, taken up by the lymph nodes, and then lymph nodes will take them to central nervous system. That's another a very dreadful thing that we don't want to talk about, but this is there when that particular, it's just like you do something and your children pay the price of it. So that's what it is in terms of the problems that normally we get for the CNS infections. Okay. Now, clinical manifestation, remember, I'm going to show you some slides. Many times what happens is that these slides are CDC copyrighted slides. And then many times people cannot understand or grasp the severity, the nature of these things. And they are standardized things. So once you see that, you're going to remember it for the rest of your life. And then again, it happens for many things for visual learners. So let me talk about the primary syphilis. The primary syphilis has a primary lesion, and it's called chancre. And chancre basically comes from the word cancer and so on and so forth. The important thing for the primary lesion is, because it is primary, so it is a sexually transmissible infection, so it's going to show at genitals. It says at the site of inoculation, of course, in this case, it's going to be genitals. And again, the way it begins, chancre, it becomes a discolored area, like a blackish area, and kind of raises up to a papule where you can feel that, and then ulcerates. Typically painless. That's the important thing for this ulcer. Painless, highly infectious. And then many times patients don't take care of it. It heals spontaneously, and they think that it's all over, but it is not all over. You have just begun a journey from primary syphilis to secondary syphilis, and then tertiary syphilis, so on and so forth. So what you will see is lymphadenopathy, which is typically classically rubbery, painless bilateral. So these are some classical signs of syphilis that we normally see. If you were to find the patient in that stage, especially for primary, if you test for serological tests in terms of an antigen antibody, you may not see, you may see a negative result, a negative result. Okay, so that's what important is. Okay, now before I go on to the next slides, show you the lesions on the genitals. Also keep in mind, because the sexual practices in people have been changed. We used to think that when I say genitals or the utensils people use for their sexual activity or vagina and penises, but this time we want to add rectum to it, we want to add throat and oral cavity to it, so you can expect all these different places that people have may also show chancres and may also show primary lesions. So anyway, this is the primary syphilis. And as a rule, both in male and female genital, you would never see an ulcer there. The skin is pretty tight, and skin should not have any problem. But if it gets to that level, that's highly contagious. That's highly contagious, and this is a typical chancre. Happens on the glans penis in male, and even in the shaft of the penis over here. And this is a typical primary syphilis we call penile chancre. And then again, as I said earlier, it can also happen on labia in female as well. So you can see over here a typical labial chancre that exists in people who are having syphilis or STI or STDs. Now, as I said earlier, sexual practices of people have been changing, and so we are adding up more sexual organs to their list, and then again you may have a perianal chancre as well. A perianal chancre that again is a primary syphilis, and those of them who want to go for oral sex, they may have a chancre on the tongue. So these are some of the things that are happening, and these are the things for STD clinics and STI people. I mean, it may look funny to you, but it's not that funny. It's a very serious health issue. And then again, secondary syphilis is, again, remember, people may have it, keep it to themselves, because they know the moment you're going to see a patient is going to come with a chancre on labia or penis or shaft of the penis, you immediately think there's a problem there. There's no other problem, STI. So people are kind of shy, and people don't want to show up over there, but they may heal spontaneously. And then again, lesion can develop and into secondary syphilis. So secondary syphilis is where your skin and mucocutaneous response. So that's important for you to know, especially for the clinical manifestation. Is going to be rash. Rash is very important, and remember, as a rule, I said that don't give opinions on rashes and things of that nature. It's a serious issue when it ties up with history of this kind of activity. Lymphadenopathy, malaise, mucus patches, condylomata lata, I'm going to give you a picture for that, alopecia, liver and kidney involvement, splenomegaly is occasionally present. And serologic tests are usually highest. So this is where you get all those antigen antibody tests positive. So this is the secondary stage of syphilis where these tests are positive. And again, as I said earlier, the idea for the workshop, the idea for this thing is if you happen to come across a situation anywhere, you at least know the basis of what the problem is and where is it coming from. So the rash is the most important thing that almost, if I was to say 100% of patients who have secondary syphilis will show. And this is how it looks like. It's called papilloscomic rash. It's like a papilloscomic rash. And by all means, if you were to look at this rash, you would say it's a drug allergy, it is such and such, but it has to be tied up with the sexual history. There's going to be a lot of other things happening, but it's a papilloscomic rash. It's like a little bit of colored eruption. Very difficult to diagnose, but the slides I'm going to give you next are easy to diagnose, because very rarely you'll see anybody else other than a person suffering from secondary syphilis to have that. And these are called palmar and plantar rash. If you know a little bit of dermatology, you will see that palms, skins, and plantar fascia, male glans penis, they have a special type of a skin where you should not see any rash. But if there are rashes over there, there's a very strong immune response. So you can see this called a typical rash, palmar, and plantar surfaces of these people. Okay, and sometimes these are also called penny and dime, that kind of a rash. They may also have a secondary body rash, so you can see the whole body may be involved, secondary body rash. And sometimes they may have a very specific, especially in females, when they have this primary chancre at the labial folds, and then it goes to a secondary papulopustular rash. This is how it looks like. So it's going to be papulopustular rash. And then again, what may happen is that this secondary syphilis then may go up to something which we call it condylomata lata. So that's a very specific growth kind of a thing that may look cancerous, and especially it is there by anal canal, a typical condylomata lata. So it looks like a cancerous thing, but this is out there. As I said earlier, secondary syphilis may have a lesion which is called nickel and dime lesion. This is how it looks like, nickel and dime lesions. Nickel and dime, so that depends upon the sizes of that, nickel and dime lesions. Some of the secondary characteristics are non-specific. So if your partner starts losing hair, don't blame it on STI. This is non-specific, right? So secondary syphilis, alopecia is also important. But the most important thing that you have to keep in mind is latent syphilis. So that's where the problem is. You have a good immune system, it suppresses the infection, you don't see any lesion there, and you think everything is okay, so I'm going to do what I've been doing. And then again, the only evidence at that point is a positive serological test. It can occur between primary and secondary stages. But again, we divide this latent syphilis, something that hides, something, because remember, if there is a pain would bring people to emergency. Pain will bring people to doctor. If a person has that kind of lesion, chancre on penis or vulva or something like that, that should bring him or her to emergency. But the problem with syphilis is painless. Right? The only thing you will see is injury, a tissue injury, right? And then again, you know for sure they're going to ask you so many questions out there. You're going to ask for the partner and sexual history and so on and so forth. So people will go for other means as well. But latent syphilis is very early latent, less than a year infection, and latent is more than a year duration. And as the Surgeon Journal of US used to say, and I may have it in one of my lectures, I'll show it in virology, that if you have a sex with someone, so you basically are having sex with a person, of all the person that he or she have had sex with in the last 20, 25 years. So that's pretty much a carryover of baggage that you should be looking for in terms of one single act of sexual activity in terms of having STI and STDs. So neurosyphilis, again, when it goes and invades central nervous system, important point is that it can occur at any stage. It can be asymptomatic, and that's where the problems come, when things are asymptomatic. And early neurosyphilis occurs a few months to a few years after infections. And then again, this is how they present: acute syphilitic meningitis, meningovascular syphilis, and ocular involvement. And many a time you don't see that involvement, but it comes decades later. So decades later it comes, and then you typically see patient having journal paresis. A typical disease that syphilis causes is called tabes dorsalis. I'm not going to teach you, but remember, I'm pretty sure that Dr. Alfie may have mentioned that, tabes dorsalis. And then again, ocular involvement may occur in early or late. Neurosyphilis has been a very serious issue, especially for those babies who were born to mothers having syphilis in the early days. So if you were to take like post-mortem biopsy of those patients who die of syphilis, you can see spirochetes, again the corkscrew kind of in the neural tissue. So you can see they are prevalent over there. So that was like a latent, primary, secondary, and then again tertiary. Tertiary is where Uh, 30% of untreated patients will progress, and it is, well, I mean, I hate to say that, but I have to admit it's been one of the, I would say, tragedy of medicine, or tragedy of, I don't know what word should I use, but it has been there and documented, especially in USA, when some of the medical people withheld treatment to African American populations to just find out how would the tertiary stage of syphilis look like. So they were not given antibiotics, and they wanted, and then again, if you know the history, even the President of the United States had to apologize for that, but that was a medical tragedy, or medical, whatever you want to say. So that, for now, it's rare. You should not withhold that. So there's a very serious ethical issues. And I remember a couple of months back, I saw the last of those people who were there involved in that case were compensated, and they pretty much have died. So you should not see that, hopefully, especially in this part of the world. But if you Google it, there have been a case that it was done right in this country. So manifestations of the tertiary stage is gummatous lesion, cardiovascular syphilis. Again, typical serpiginous, like a serpent-like, snake-like, as you see the microorganism, is called gammata. Remember, I used the term granuloma for chronic infection. When you say gamma, when you say chancre, these are very specific terms that we normally use on the forearm. Serpiginous, snake-like pattern of late syphilis, and again, late syphilis, ulcerating gamma. So these were probably those patients that were not given antibiotics and so on and so forth. It can also affect cardiovascular system, late syphilis. And then finally, a few words on congenital syphilis. As I said, vertical transmission passes from pregnant women to her fetus and may lead to stillbirth, neonatal death, and infant disorders like deafness, neurological impairment, and so on and so forth. This type of transmission can take place at any stage of syphilis, though risk is higher during primary and secondary, because primary and secondary are the time when these patients are very contagious. And then again, there could be many different kind of lesions that we normally see depending upon. But again, remember that the chances are, of course, if there's a health disparity there where mothers were never tested for STDs and they would not know their immune status as to what is going on in terms of they having ready for pregnancy and safety of the baby, so on and so forth. But the public health is really doing a good job in making sure. And as I said the other day, that if a person has one STI, they always test them for other STI, because this is a pattern there. So if you are in that kind of a business where you are promiscuous, so you are acquiring not only syphilis, but all the bacteria, viruses, and parasites. Many a time HIV, many a time HSV, many a time HPV. So you want to make sure that we test you for almost everything that possibly can happen. Congenital syphilis, mucus patches, you can see typical in the babies. This is congenital syphilis. Classical, we call Hutchinson's. How would you diagnose it? And as I said, you will come for a workshop as well. I don't want to put much of a pressure on you, but you can, I think, pretty much determine by now the most important thing for picking up the syphilis diagnosis is the clinical history. So there is a history of pattern there. Well, again, as I said earlier, very difficult to get sexual history, because the problem of STI is that you don't treat the patient, you treat the partners. That's why if you see the classical cases, partners could be many. So people at the most will say, oh yeah, I have only 6 partners in the last 6 months, but they will not tell you what happened in the last 6 years. So, but at least for our practical purposes, we need to treat the partners. So there is a disclaimer there. There is something that you need to take out, develop confidence, and so on and so forth. So clinical history and physical examination, as I said, if you see a lesion like that on the genitals, you got it. This cannot happen other than STD or STIs. So any growth, any ulcer, any discoloration on the skin of penis, vulva, anal canal, and as I said, mouth as well, can lead to any of the problems that these people may have. Of course, you would go for lab diagnosis. And if you were to work, I remember I told you there was one student, she was working in STD clinic, and it was challenging. You want to take history, non-contact, typical signs and symptoms in the last 12 months, and then test for serological syphilis. And as I've been saying over and over again, that since the sexual practices of people are changing, so I don't know whether we should still call it STI or we want to come up with some other word, but the physical examination, you want to make sure that you look at their oral cavity, you look at all their lymph nodes, you want to look at all part of their skin, you want to look at their palm and sole, of course you look at the genitalia and perianal area, you want to examine neurologically, and you want to look at the abdomen. So these are very generalized physical examination that you may see a lesion in any part of the body that is there, that has come in direct contact with your sexual partners. For lab diagnosis, again, as I said, dark field microscopy, and there are tests available. I think if you remember for now, serological tests are called non-treponemal tests, treponema because of the microorganism, or the treponemal test. So these are the normal terms that we normally use, just for your information. If you want to look for the dark microscopy, you want to look at the morphology, motility, and then again there are disadvantages, you don't want to know them. And for serological tests, which are more important, treponemal test is a qualitative test, whereas non-treponemal tests are both qualitative and quantitative. And then again, for all practical purposes, if you want to use only one type of serological test, that may be insufficient for diagnosis. And then again, there are some other sets of tests which are there. I would just want you to read while you sit today for your workshop, and maybe you may have some objective questions to write for that specific case. I'm just going to go through that. But you will see quite a few tests available for non-treponemal serological tests, like Venereal Disease Research Lab, VDRL. That was very famous test when initial 1940s. Trust and many different tests which are available. And they both have advantages versus disadvantages. Again, if the need be, you can refer them. But the most important thing that you have to keep in mind is that when we want to look for serological tests, we basically are looking for antibodies. So basically, we are measuring antibody directed against Treponema pallidum, right? Or we want to go for antigen. And these basically are good enough for us to figure out, especially if you want to treat patient, whether the levels are going up and down. So load, we call load of bacteria. For example, if there are more antigen load, more bacteria, less antigen load, less bacteria. And then again, there are sensitivity tables there for your information only, but you will see most of them over here have like if you are in a primary, these are the options of the test. You can see most of the tests are 100% specific for secondary. That's where the important thing is. And then again, latent and tertiaries, we have pros and cons depending upon whichever tests are there. And then again, there are many false positive reactions for serological tests. And then again, as a pharmacist practicing in infectious diseases, but as a pharmacist practicing in STD clinics, you really have to keep your eyes open, because you may have a false positive reaction when you have all different kind of diseases. So there are some of the diseases that you want to make sure that you don't want to label a person suffering from syphilis because he or she has a positive test, because there could be some other things going on even malaria, leprosy, and so on and so forth. So these are some of the, you call it differential diagnosis before you establish your diagnosis for that. So diagnosis of the latent syphilis, there is a criteria there by CDC. There are public health issues, there are laws, there are things that you need to report, so on and so forth. But the point over here is that by the end of the day, two important things that you need to know for diagnostic issue. Number one, CNS disease can occur during any stage, and then conventional therapy is effective for vast majority of immunocompetent patient. But also remember, if the patient is HIV, he or she is not an immunocompetent, and if you have HIV plus syphilis, so it's a double whammy, it's very difficult to treat. And when you have a infection of the brain, for example, CNS involvement, of course, you need to do a cerebrospinal fluid aspirate and run a test for that. Again, there are indication and diagnosis. I don't want you to go into that. There's always an HIV issue. HIV has an issue with every STD because of the nature of the disease and because of especially the important thing in terms of lowering your immunity, especially T-cell mediated immunity. Patient management is something that you will learn today in workshop and answering those questions. And management is different, especially for primary, secondary, and early latent syphilis. But the most important thing that you can see from here is a benzathine penicillin G, 2.4 million units given intramuscularly in a single dose. And then again, rest of it follows. But that's what I said, the magic drug that people thought was a license to kill, and then they didn't change their behavior, but it came back over and over again. Therapy is there for latent, therapy is there for tertiary, and therapy is there for neurosyphilis. All these are there for your information. I'm pretty sure that you don't need to kind of remember that as you work in that category. They would have prepared you notes and charts, and you can refer them. But one thing is for sure, that when you are dealing with a patient who are pregnant, that's something that you have to make sure that you have basically, as we say, go by the book, go by the CDC recommendation. You want to make sure, because by the end of the day, CDC does monitor and it does give you treatment guidelines, and then they are by vast majority acceptable. The only alternative acceptable sources will be, like, for example, American Association for Infectious Diseases, bigger board, American Association for Medicine, and some other big American Society for Microbiology, things of that nature. Otherwise, pretty much CDC has laid down, and they keep on updating that. The other question you will normally see as one of the distractors, because today's lecture is also a part of not only workshop, but it's also part of your exam too as well. Jarisch-Herxheimer reaction, that's very important, because this is classically known as a self-limited reaction to anti-treponemal therapy. So if you give this therapy for syphilis to the patient, these patients then develop this response where they have fever, malaise, nausea, and a secondary rash. So this is self-limited. It occurs within 24 hours. It is not an allergic reaction to penicillin. That's what you need to know. Because you may give them penicillin, and then you think, oh, they have got allergy to penicillin. This is not an allergy to penicillin. It is basically a self-limited reaction to the therapy that you just initiated, Jarisch-Herxheimer reaction. And all you need to do is that you just need to give antipyretics, and be careful when you are dealing and treating pregnant women. And they basically should be informed that, especially when you're dealing with pregnant women, you want to give them something. It can initiate labor. It can precipitate early labor. So these are some of the things that you want to call for obstetricians' help, and want to make sure that everything's done under control. Okay, as I said earlier, syphilis and many other diseases are typically present, coexistent, so to speak. And then again, you treat the patient. You want to make sure that they not only get treated, but you follow them up as well. So there's another issue, patient compliance. And then you can see, depends upon which stage of disease that you got your patients in, primary, secondary, HIV, and neurosyphilis. There is a follow-up pattern for each one of them. The question your patient may ask you, and you may want to know, are there any treatment failures? Well, the answer is that, of course, there are probably indication for treatment failures or reinfection, because there could many things happening, and you want to make sure that your drugs are acting against and lowering the burden of that particular microorganisms. Since it's a public health issue, then again, you want to do prevention as well. Patient counseling is important. You want to explain to the patient what is the nature of disease, what is it that they need to change, and how this is transmitted, how you follow up, how can you reduce the risk reduction. You need to manage their sexual partner. And then again, there's a protocol that you need to follow. And then again, you want to make sure that CDC, for all practical purposes, would recommend that especially their sexual partners be treated in any stage of the disease. And as far as screening is concerned, we do screen pregnant women at least at the first prenatal visit, because it is, especially in high prevalence communities, as we just said, they are to be tested twice during the third semester at 24 weeks and delivery. So that's kind of a routine. So the other important thing is any woman who delivers a stillborn infant after 20 weeks should be tested for syphilis, because that's one of the commonest causes that we normally see. And then again, depends upon the patient risk behavior, depends upon the patient, local prevalence in the area of your practice. And you can also. The question then again for STI very commonly, and I think you should remember that as what are the laws? What does it got to do with me in terms of legal perspective? So that's very important issue for some of the diseases that you see. There are laws and regulations in all states require that person diagnosed with it are reported to public health authority. So this is a law there. So this is a law, and then again you have to follow up with patient with early syphilis in a public health priority. So this is a public health disease. There is a public health concern, and you should be aware of that, and you should also try to follow that. And the last thing is a case study, which basically you will get it in today's workshop. Again, remember, most of the time when I used to present this case study, I look at the names of all the people and want to make sure that doesn't accidentally has the same name in my class. But ever since we have so many people, so I don't really bother to do that. But if it's such a name, that's only accidental, coincidental. So this is a very carefully selected case in this case. A typical person, give you the whole history. You want to look at the physical examination. And then there are some of the questions that basically are related to this particular patient in the light of the preceding information that CDC presents you. For each and every question, there is an inherent motive for your learning. And that's what I'm trying to get at. So you want to pay attention to it in terms of stat that you normally get in terms of lab results, what are the other things, and typical sexual history of whatever was going on and what kind of response was done, and so on and so forth. So I'll just finish up with the last slide, which is again the most important thing for these particular patient is that how do you follow them up and how do you send them home? And you want to make sure that they pretty much are taken care of in terms of a follow-up evaluation and in terms of the symptoms and in terms of counseling that they may have. Okay?